Okay, let's begin. Welcome everyone to today's webinar. I'm excited that you are able to join us for this really pertinent topic. Today's topic is shifting sands of COVID-19 regarding healthcare law. And it's my privilege and opportunity to be able to introduce our panelists to you. Lowell Brown, who is a partner at Arent Fox, and he's a co-leader of nationally ranked healthcare, and widely recognized as one of California's preeminent medical staff lawyers. And Professor Leslie Francis, who holds joint appointments as the Alfred C. Emery Professor of Law and a Professor of Philosophy, and is the director of the law school's labs program, the Law and Biomedical Sciences Center. Just a few logistics before we get going completely. Please, if you have a question, use the Q&A feature at the bottom of your screen. We will then rank the questions by how many likes the questions get, so we can get the questions answered that you are most interested in first. Also, please don't try to use chat, that won't work. And at the end of the presentation, the video will be on our YouTube channel within 48 hours, and we will be sending out the slides to everyone by way of email. So watch for an email from me, Lori Nelson. With that brief introduction, I'd like to turn the time over to Lowell Brown. Lowell, thank you very much.
Thank you, Lori. We're very happy to be here today. I am sure that there are some people in the audience whom I know, and I look forward to having more than just a virtual meeting with those folks sometime in the future. I am really happy to be here with Professor Francis and to speak with her. Let me show everyone an overview of what we'll be talking about today. I'll talk about institutional issues as the law has evolved and as it affects organizations like hospitals and health systems, nursing homes, and so forth. And that will cover quite a bit of ground. And then Leslie, Professor Francis, will take over with issues that are really in her sweet spot relating to bioethics and privacy. And we'll both probably have something to say about what's happening next with the return of elective services to hospitals. So beginning with what's going on in hospitals everywhere, I am a hospital lawyer, and so most of my clients are hospitals. I will say that the healthcare industry is second only to nuclear power in terms of the level of regulation that it faces. That tells you how much regulatory activity goes on in this world. I think the title of the presentation about the shifting sands of healthcare law in relation to COVID-19 is an appropriate metaphor, because as we'll discuss now, we're kind of in a legal desert in a way, in that the landscape is wiped clean of rules that we thought applied, but aren't applying anymore, or not in the same way that they were. And then the landscape keeps changing. We get new facts, new rules, and we learn more and more all the time about the virus itself. So let's talk about suspension of regulatory requirements at the state and federal level. This has been a fascinating phenomenon for people like me who spend all of our time dealing with helping hospitals deal with the regulations that they affect. In my state, in California, we have something called Title 22, which is a very long, several binders full of regulations, back when people actually used binders, that regulate the healthcare industry. We had in California an emergency declared by our governor, Gavin Newsom, and it was quite shocking to all of us. We knew things would change, but we didn't know this would happen. He authorized the director of our public health department to waive any of the licensing requirements of our health and safety code and the accompanying regulations. That's where Title 22 comes into play. So, for example, the Department of Public Health sent out what they call an all facilities letter on March 20th, saying that they were temporarily waiving licensing requirements and suspending regulatory enforcement of all licensing requirements for hospitals. And they make some exceptions. I will tell you that this puts us in what I would call the Wild West. There was a time when we watched our step all the time regarding the regulations, and now we are looking at a clear path. we won't go over all of these exceptions. They're the kind you might expect. Hospitals need to follow their disaster response plan and obviously follow the COVID-19 infection control guidelines. And the third one down is the one that everybody is living by right now, which is to provide necessary care in accordance with patient needs and make all reasonable efforts to act in the best interest of patients. In other words, they were saying to everyone, and the attitude we've gotten from them is, do what you need to do to take care of patients, and we'll talk soon. And I'm not exaggerating very much. Another example that affects every hospital in the country is EMTALA, which for those who aren't familiar with it, that stands for the Emergency Medical Treatment and Labor Act of 1986, a statute that's been with us for a while. The Centers for Medicare and Medicaid Services oversee that law, and we deal with them all the time when we're trying to deal with an EMTALA compliance issue. It's very important law for all hospitals, because if you are found to be out of compliance with the law, you'll end up in a Medicare termination action, meaning it's a formal process whereby Medicare, the Centers for Medicare and Medicaid Services, or CMS, will tell the hospital, you need to correct this problem, usually within 45 days, sometimes 23, sometimes 90. And if you don't, we will terminate you from the Medicare program, which gets the attention of all hospitals, because they will not survive if they're not in that program. So just this was the already challenging environment that EMTALA creates for every single hospital in the United States that actually has an emergency department. If someone shows up at the hospital and requests evaluation for treatment or treatment of a medical condition, in other words, I'm here at the hospital, I don't feel well, please help me, EMTALA is triggered. First thing that has to happen is that the individual receives a medical screening obligation. That's defined. There are regulations detailing what that means, to determine whether the person has an emergency medical condition. If they do have such a condition, then the hospital is required to provide stabilizing treatment, also defined in detail. If you want to send that patient away from your hospital after you've found an emergency, the transfer has to be appropriate. Appropriate is defined, and there are several regulations that explain what that means. You can't send a patient away unless the transfer is appropriate. And the receiving hospital, another hospital, let's say if the patient comes to the first hospital and can't be cared for at the first hospital for whatever reason, they can be transferred to another hospital that does have the capability to treat the patient, and that hospital must accept the patient. So that's the world that we have lived in for a long time, and every hospital is familiar with these rules and knows how to comply and does training on a regular basis. Well, after COVID-19, the regulations changed, and you can see how the Wild West applies here. So if a COVID-19 patient comes in any way, they walk in, they come by an ambulance, the emergency department is still supposed to provide that appropriate examination, but they need to apply the COVID-19 screening criteria. If you followed COVID-19 at all, you know those criteria have changed. We've learned more about the virus as time has gone on. So every emergency department in the country now has to be on its toes in terms of how to apply those criteria to a screening examination. They have to identify and isolate people who are potential COVID-19 patients. So we have what our clients call the worried well. These are people who might have COVID-19, but they're not sure, they just feel ill. They have to be screened as well. And so you probably go through 100 people before you find 5 or 6 who actually have the virus. And then finally, the last thing is that if you find somebody who does have COVID-19, you're required under federal law to contact your state and local public health officials. So the world of EMTALA for every emergency department in the country has changed. How do you stabilize a patient with COVID-19? Well, you have to follow current Centers for Disease Control or public health official guidance. And if you've been watching the news, that changes all the time. Again, a way to have to be vigilant about what hospitals are doing. Can you stabilize this person? What does it mean to stabilize somebody with COVID-19? That's a question nobody has really answered yet. very well. Hospitals also who are presented with a patient saying, let's say the first hospital says, we can't take care of this patient for whatever reason, we're sending them to you. That hospital can only refuse that patient if they don't have the room for the patient, for example, or other capabilities or capacity to take care of the patient. CMS it analyzes capacity. How much room do you have based on what your historical practices have been when your emergency department is full or busy? Well, that used to mean that patients would be in the hallways and in rooms that weren't otherwise used for emergency patients. With COVID-19, it's very different. And so people are saying we don't have room for that patient because we don't have a place to isolate them. Anyway, so, and finally, CMS gives the rather unreassuring guidance that if there are complaints about transfers that weren't appropriate or refusals of transfers, we'll consider the public health guidance that was in effect at the time. So we'll get back to you on whether you actually violated the law. I'm not complaining about that. It's just how, and a great example of how uncertain the world is during this time. Supply issues. This is, I'm not going to have much to say about the law here other than some anecdotal experiences that implicate the law. Ventilators, everybody heard about those. There was a scurry early on to find them. Now we have found that, well, if you're in a risk group over a certain age, you probably have a 30% chance of ever coming off a ventilator. Other people might have a 50-50 chance. And providers are finding that they want to use those. They don't want to use those in the cases that they thought they did before. So we have lots of ventilators now sitting around unused. PPE or personal protective equipment. A lot of people, because they knew I was a healthcare lawyer, a hospital lawyer, started contacting me early on and offered me great deals to offer my clients about getting gowns, masks, ventilators, all kinds of things, face guards, at great discount prices. They said they could provide 100,000 of them at XYZ price. We got that a lot. Hospitals were approached by construction equipment companies saying, we have face masks that aren't really medical, but you could use those. And hospitals were buying them. We had donors, hospital donors, benefactors who had been longtime allies of a hospital who were offering to purchase equipment or who had purchased it and came to the hospital saying, I've got 200 ventilators or 10,000 face masks. That led to issues about the warranties of fitness for that equipment, and it was very complex because if you accept donated equipment that's protective and it's flawed or it fails, frankly, who gets sued over that? And so there were all kinds of questions about fitness warranties and who was going to warrant their fitness. Lots of donors ended up with a lot of equipment that they couldn't donate because the hospital didn't have the heart to make the donor responsible for failures. Just an example of how the law and these issues intersected. Immunity statutes. Lawyers, we are lawyers, and there are certain lawyers who look for opportunities to find liability. And if there was a failure of care, patients died because of mistakes that were made in treating COVID-19, because not enough was known about the disease to treat it properly. There was a movement to immunize hospitals and other providers, physicians, for example, for that kind of error that would be unforeseeable. New York and Utah have examples, and there's also something that happened in California. New York, there's the New York statute, and it's quite typical. It provides a qualified immunity. You've got to be a provider who's treating a COVID-19 patient. Treatments impacted by COVID-19, very broad language. Key provision is you've got to be acting in good faith, and this doesn't apply in cases of willful misconduct. Also applies to volunteer organizations, Red Cross or other charities that get together to try to help supply manpower or person power to providers. So that's how you get immunity in New York. Utah has a very similar statute. It's too long. It's very lengthy, too long to put on a slide or discuss much with a lot of defined terms, but it basically follows New York's statute. So there's a move out there to make health providers feel comfortable doing the best they can in the wild, wild west in places like California, where people say, just do the best you can, don't worry about the regulations. California, we always like to buck the trend. We have a current statute that covers this type of activity in emergency situations. It's limited to hospitals. That doesn't include nursing homes or other type of institutional providers. And of course, it's a conditional or qualified in that you're not protected if you are involved in a willful act or omission. So in an unprecedented event, the Hospital Association, the Medical Association, the Health Plan Association, nursing facilities, assisted living, all of whom are at one point or another foes or rivals or opposed to each other in what should happen in public policy, requested an executive order from our governor. He hasn't issued one yet. So those are several examples of how people are dealing with legal immunity for errors or just bad outcomes that result for patients in this new area. Tests and vaccines. Not much legal here other than to give you the environment in which the law is trying to function. The law is way behind. Just so everybody knows, this is what happens when you are getting a corona disease test. It's this recommendation from the CDC, the Centers for Disease Control. They use what's called a nasopharyngeal swab. We'll talk about that in a minute. And this is wonderful. You have a 6-inch cotton swab up both sides of your nose and move it around for about 15 seconds. It won't hurt, but it might be uncomfortable. I've heard from lots of people that it does hurt. Anyway, that's how that test is done. And this is what it looks like. Just in case you're thinking about getting one, you'll be prepared. Talking about supplies, there was one company in the United States named Puritan in Guilford, Maine, population 1,500 and some. It's the only company in the United States and one of only 2 companies in the world that makes the swabs that are used for COVID-19 tests. The other company is in Italy, which for lots of obvious reasons didn't have a lot of swabs available to import to other countries. So, and the Puritan is making millions and millions and millions of swabs. In fact, there was a recent event, which is sort of comical on a nonpartisan basis. President Trump visited the Puritan factory and he and his team didn't wear face masks. And so all of the swabs that were made that day had to be thrown away. Just an example of unexpected events in the world of COVID-19. Testing issues create legal concerns as well. Labor and employment lawyers have been struggling with what are testing requirements that are possible for employees. Must you pay your employees for the time that is spent taking a test? The answer is yes, at least in California. What about sick employees? Especially if it's in a healthcare environment, they're going to be quarantined for at least 14 days and not longer. You have to worry about antibody tests, talk about asymptomatic employees. All of those things are issues that labor and employment lawyers are dealing with, which is beyond the scope of today's presentation, but just highlights for you the issues that have come up. Adequate personal protective equipment. We had one of my clients in Los Angeles, a number of nurses walked off the job because they didn't feel like they had appropriate face shields, masks, gowns, and so forth. Many hospitals in California are unionized, and so that was a union issue, and it was worked out, but it's an example of headaches that come our way because of COVID-19 and it's the unusual stresses that it creates. Now, it's time for me to turn the presentation over to Professor Francis, who will be talking to us about triage law and bioethics and a lot of related subjects.
So thank you all very much. I'm going to try to share my screen with, let's see, presenter view. play from current slide. Is that working as it should be working? And can everyone hear me appropriately?
Yes,
Okay.
it's working and it looks great.
Okay, so what I'm going to talk about first are the kinds of issues that emerged early on when people were very worried about whether there were enough ventilators or enough intensive care units, or actually now enough of many other kinds of care modalities. For example, dialysis machines are turning out to be potentially of interest in this. I'm going to look mostly at the law here, a little bit at the ethics, and then I'm going to turn to privacy questions. So let me start with Section 1557 of the Affordable Care Act. Then I'm going to look briefly at some of the allocation protocols that states initially basically just dusted off what they had on the shelf from fears of influenza about 10, 15 years ago, and then how anti-discrimination law kicked in on this. So Section 1557 of the Affordable Care Act prohibits discrimination in federally funded health care on the ground, and ground is singular in the statute, prohibited by Title VI of the Civil Rights Act, Section 504 of the Rehabilitation Act, Title IX of the Education Amendments, and the Age Act of 1975. These are each statutes that prohibit discrimination in a federally funded program. For Title VI, it's race, color, or national origin. For the Rehabilitation Act, it's disability. For Title IX, it's sex. And for the Age Act, it's age. An open question that we actually don't know the answer to is whether ACA Section 1557 creates a new cause of action that's similar for all of these, and the reference is just to the categories, or whether what Section 1557 does is pull in all of the differences among these statutes, including things like whether they allow for private rights of action by individuals. That may turn out to make a major difference if there are harms from discrimination. So what did the allocation protocols actually look like? There were a number of pandemic plans that predated the ACA that listed age and disability factors as grounds for not putting people on ventilators. So in Alabama, for example, ventilators were not to be offered to anyone with severe or profound mental retardation, moderate to severe dementia, or severe traumatic brain injury. Disability rights groups brought suit, or actually filed complaints about these standards. Two of the complaints came from Washington State and from Alabama. And they, HHS quite quickly pointed out that these were in violation of the Rehabilitation Act and of the ACA, and they were withdrawn. There are, however, many of these standards that still embed in some way or another factors that may be violations of ACA Section 1557. I'll give you as an example, Utah's COVID-19 addendum to their pandemic planning. What Utah has, you do if you're a hospital, this is what Utah says you should do. It doesn't require you to do this. But you first use a way of scoring predicted differences. And then there are, if you've got ties between otherwise similar patient groups, Utah says, don't recommend for intensive care patients who have a do not resuscitate order, patients who have advanced cancer, patients who have severe acute or chronic neurologic condition. And actually, also in Utah, if we're in situations of great scarcity, age may come in way down as a tiebreaker in some states, although not. Utah only puts age in as a tiebreaker when there are predicted differences in outcomes. On the ethics front, there have been a number of publications. Probably the most influential one is Ezekiel Emanuel and others that was in the New England Journal that said, look, what we ought to be doing here is being good stewards of resources. And what that means is we ought to be trying to either maximize the numbers of lives saved or the number of life years saved. Recognizing that those two are different, they said, try to work out a reasonable balance between them. But they did end up saying that age and significant illness could lead to deprioritization if it meant that you save fewer lives or fewer life years. And that recommendation, which, as I said, has still got influence kind of buried way down in some of the allocation protocols, has been the subject of a great deal of criticism from various disability rights organizations, also from folks representing the elderly and the American geriatric physicians groups. So here's actually what the Office of Civil Rights said in response to the complaints, that, hey folks, we're enforcing Section 1557 and Section 504 of the Rehab Act. And here's a quote: HHS is committed to leaving no one behind during an emergency, and this guidance that we're giving you is designed to help providers meet this goal. Persons with disabilities, and HHS went actually further than the actual ACA here. Persons with disabilities, with limited English skills, or needing religious accommodations should not be put at the end of the line for health services during emergencies. Civil rights laws protect the equal dignity of every human life from ruthless utilitarianism. That's what the director of OCR said. And here's the language about disabilities, that no denial of medical care on the basis of stereotypes, any quality of life assessment, or any judgment of relative worth based on the presence or absence of disabilities or age. Any decisions made by covered entities about allocation should be based on an individualized assessment of the patient using the best available objective medical evidence essentially about survival. Okay, so that's where we stand with allocation. Hopefully, our surges will not get so that we have to face those issues with respect to intensive care, but we have to remember the importance of no discrimination based on disability or age, even when decisions are made about whether or not to refer a patient for hospitalization from a nursing home, for example. So now let me turn to privacy. The primary statute is the Health Insurance Portability and Accountability Act and the regulations. This is federal law and the regulations under HIPAA. The Office of Civil Rights has issued a number of documents, bulletins, and guidance regarding the interpretation of the HIPAA privacy rule in the situation of COVID-19. So in February, very early on, HHS said HIPAA strikes a balance between the appropriate protection of patient privacy and uses and disclosures of information when needed for treatment, protecting public health, or other critical purposes, public safety, for example. For treatment, HHS said explicitly, you can use protected patient information either to treat the patient in front of you or to treat other patients. So under HIPAA, for treatment means that you could use information about my COVID-19 diagnosis to treat people I might have exposed, such as my family members. To the best of my knowledge, that's one of the first explicit statements by HHS that for treatment means for treatment of anyone, not just the patient in front of them. Secondly, HHS emphasized that HIPAA permits disclosures as authorized by law for surveillance and for public health efforts, such as preventing or controlling disease spread, carrying out contact tracing, and the like. In this bulletin, HHS also reiterated that HIPAA permits disclosures of information relevant to a current episode of care to persons involved in the patient's care if the patient has an opportunity to object and doesn't, or if the patient can't because, for example, they're unconscious or intubated and can't speak, when in the healthcare provider's best medical judgment, sharing is in the patient's best interest. So people who are in ICUs, family and friends involved in their care aren't shut out, although sometimes people mistakenly believe that that's true. So a second bulletin from HHS in March involved what can be shared with first responders and public health. Again, reiterating, it's permitted when necessary for treatment, when required by law. HHS also said, on a per-call basis, information may be shared with first responders who may have been exposed. Information may also be shared when necessary, minimum necessary here, to prevent or lessen a serious and imminent threat to someone who may prevent or lessen the threat. So, for example, it could be shared with child welfare workers, other social workers, and the like, if necessary to prevent or lessen a serious and imminent threat. And it can be shared with law enforcement officers responsible for health and safety of individuals at a healthcare facility. A little bit of additional guidance came out in May. Don't let the film crews in to talk to famous people who might be hospitalized with COVID unless you get HIPAA authorization from anybody whose information might be accessible. So if a film crew might inadvertently film somebody else, you can't let them in. And this was a very useful reminder because, of course, there's a lot of interest in what's going on with public figures who might have been diagnosed as COVID positive. And then just a couple of days ago, the question was addressed about whether healthcare facilities could contact patients they knew had recovered to ask them whether they would be willing to potentially donate plasma for use in treatment of current patients. And the answer there was yes. So that's a quick rundown on HIPAA. Briefly about the return of elective services, who gets to choose, and how to think about this. You've got everything from what a state is saying to what courts have said about what a state is saying, for example, with respect to whether abortions are regarded as urgent. And then you've got questions of informed consent for patients, because there may be decent reasons for delaying some kinds of non-urgent care that might, say, immune compromise a patient. So with that, I'm going to stop sharing my screen, and we can open it up to Lowell's comments. He may have some additional comments about non-urgent care, and then time for Q&A.
I don't have too much to add other than anecdotal experience. Hospitals and physicians everywhere are eager to return to elective procedures, outpatient care. Well, to be honest, hospitals derive a lot of their income from outpatient services. They pretty much break even on inpatient care. So on top of that, they have had to purchase equipment and pay overtime and incurred a lot of expenses. And so I know one system, who I won't name, that it's got 6 hospitals who says they have lost $200 million because of COVID-19. So that has an impact down the road as well. So there's a lot of eagerness to get going again. They're telling me that patients are worried about returning to the hospital for obvious reasons. And so, those kinds of issues are practical, not necessarily legal issues. But I think you're right, Leslie, there will be some pushing from some patients who want to be seen sooner than others. And that will be something that probably will result in some guidance from the regulatory authorities, and maybe even some litigation, maybe even some legislative activity. So that will be that's to be seen, to be determined, I guess.
It's posing really difficult ethical questions for physicians. I know I've been involved in conversations with primary care internal medicine physicians where the question has been, which visits can you do virtually, and which visits can't you do virtually, and how you try to, if you've got, say, a patient who really doesn't want a virtual visit, but you as a physician think that a virtual visit would actually be best because of the concern about any risk of transmission. Maybe this is somebody with with a condition that makes them particularly vulnerable, and all you're having is a check-in appointment, and you can do that. but they want to come in personally. How do you handle that? I've also had ethics conversations with oncologists who are both worried about patients who are too nervous to come in, who really do need follow-up treatment, say starting adjuvant chemotherapy, or situations in which there's a complicated question about, can you delay a bit? So for example, somebody's just had cancer surgery and radiation is recommended for, let's say, a lumpectomy for breast cancer. Do you delay the radiation for a month? Because it would require coming in daily for a considerable period of time, and would also put the patient at some risk because of immune compromise effects. So those are difficult questions, and they're not going away. And doctors are working really hard to have careful conversations with their patients so their patients can be as informed as possible.
I think that might be one of the reasons why, in fact, I understand it is one of the reasons that Governor Newsom in California declined, or has so far declined, to issue an executive order that would expand the existing protections, because he and his staff consider that to be too murky of an area to grant sort of blanket immunity to. There's too many individual situations, and it's understandable why the hospitals and the physicians were nervous and wanted to have some sort of immunity as long as they're acting reasonably. But you know, there's a great number of competing interests. There is money involved, and incentives, financial incentives, and so forth. So that will be something that just has to work out over time. But you're right, there are interesting issues, and the orthopedists would like to get the people in who need knee replacements as soon as possible. They've told me that, but unfortunately, even though I'm a candidate for that surgery, it's not as urgent as somebody who needs to get in for their radiation therapy or their pacemaker or the interventional cardiology work that they might need.
So that leads to the question, how much, if any, weight is being put on doctors from the insurance companies in person versus virtual visits? Or are the insurance companies looking at those as equivalent?
So one of the things that has happened is you can currently bill for televisits more broadly, at least for Medicare patients. And physicians are pleased about that. And actually, I think there's some hope that the ability to bill for telemedicine visits will extend beyond the COVID-19 crisis, because there are actually a lot of reasons why, if appropriately used, telemedicine can be a particularly good way of increasing access to care for people for whom it's difficult to come in, people who live far away, and the like. So I don't know, Lowell, if you've got more experience with other payers, but typically other payers will often follow what Medicare is doing.
That has been true in our experience. It's one of the unexpected, I wouldn't say a silver lining, but learnings of COVID-19. We've all learned that virtual presentations like this are more doable than we thought. And we're all used to meeting by Zoom. And physicians are becoming very accustomed to seeing patients via telemedicine. There's now teledermatology, telepsychiatry, all kinds of things where you can be virtually present. But I understand that the private payers are following the lead of Medicare. It's in their best economic interest, if you look at it carefully, to actually do that. They want patients to be seen, and it's better for a patient to be seen than not be seen, because it's more expensive to treat one who hasn't been seen and deteriorates further. So it's a kind of an almost a dollars and cents analysis.
One of the issues that has been raised about some of the uses of telehealth are the patients with various kinds of communicative differences. So how you manage, for example, a patient who is visually impaired, or a patient who is hearing impaired with the use of telehealth. I mean, it's also interestingly difficult with respect to masking if someone lip reads, for example. And that's been the subject of a great deal of discussion, particularly among the National Association of the Deaf and with respect to disability rights in the delivery of healthcare.
Also, there are requirements in most states to provide translation services for foreign language speakers, and those are trickier to do by video than in person.
Yeah. Okay. So there's a question. Have you seen the impact of COVID-19 causing the hospital industry to look favorably toward the time when the interoperability rules are enforced regarding admission, discharge, transfer, data exchange?
I can respond to that. Interoperability refers to the compatibility among various electronic medical record systems. So if the physician has one in his office and the hospital has another one, or a different hospital uses a different type of system, that's been a headache for a long time. And I think it's another example of how COVID-19 is causing people to accelerate or focus on problems that haven't been focused on as much in the past, because you could get away with postponing that sort of thing. It was annoying, slowed down care, but now it's become more of a necessity. So I think that one of the learnings from this crisis will be the expediting of interoperability, that's a mouthful, interoperability capabilities and technology. I hope so anyway.
Another issue that may be on the table with that, when the meaningful use regulations came out, which is you had to be a meaningful user of electronic medical records in order to bill Medicare, the extent to which any communication with public health was included in that was very sparse. And I would hope that there would be increased attention to the secure electronic transfer of reportable events to public health as another problem with interoperability. One of the issues there was that public health just wasn't equipped to receive communications either, partly because the infrastructure of public health has been underfunded in the US. And so the electronic capabilities of public health were not ready to receive immediate transfers from EHRs. And I haven't seen any discussion of that in any of the literature that I follow, but it would be nice if there were more attention to that interoperability question too.
Great, thanks. Another question. Initially, there was high demand for healthcare professionals to obtain licensure in Utah. The facilities did not identify a need for physicians. Do the panelists know if hospitals have seen a lack of physicians or nurses available for COVID care?
I can only report anecdotally from a California experience that that's one of the fears that we had that seems not to have been realized. That there apparently were enough providers to take care of patients. There was a concern about having enough nurses. The clients I deal with often are the in-house general counsel of healthcare systems, and they tell me that everybody, at least in California, was very geared up for what they called the surge, but the surge never really happened quite to the extent that we thought. So I can report, again, just anecdotally, that it seems not to have been an issue, at least in a huge state like California. I don't know what has been the experience in Utah.
I have not, again, I can report anecdotally that I'm on the broadcasts to University of Utah Health personnel because I have a courtesy appointment up in the medical school. And the one area where I know they've thought about, and so far there is continued privileging in other states, is the delivery of more in the way of telehealth out to, for example, people in Montana or Wyoming. You know, I don't think the University of Utah, I haven't seen any evidence that they're short of personnel. They've wanted to make sure, because sometimes now their providers are offering telehealth services to people in other states who otherwise would travel here to Utah to receive their care. And so far that's been worked out adequately too.
Well, in terms of personnel availability, doctors tend to be more specialized than nurses, if I'm correct on that. So it would seem that doctors would have less work. The orthopedists, those types of physicians would have less work to do than maybe a generalist or a nurse, because their abilities might more easily translate to COVID treatment. Is that accurate, or?
Well, actually, that's an interesting point, Lori. Let me share some experiences. We had, within the Los Angeles County has its own healthcare system, which consists of 4 hospitals, and it's heavily used, very, very large medical staffs and large patient loads, and teaching programs in all 4 of the hospitals. So big residency programs. They're very sought after residencies for lots of reasons. And the residents there were told in preparation for the surge, well, I know that you're in a psychiatric residency, but you're now in an internal medicine one. And everybody is going to be on call all the time to take care of COVID patients. Now, the need didn't materialize to the extent that they thought it would, but that's an example of how they tried to gear up. Also, in other health systems, you have individual hospitals. Maybe you have a 6-hospital system, for example, and each individual hospital has its own group of physicians called the medical staff, and those physicians have privileges at that hospital, but not at the other hospitals in the system. So Hospital A might have a bunch of pulmonary specialists who would really be helpful in dealing with COVID-19 patients, and Hospital B in the same system 10 miles away might not have any pulmonologists, but they're in the same system. And so they set up, using the Wild West regulations that I talked about in California, they made it possible for physicians to float freely among hospitals so that they could cover patients that needed that type of specialty. But also, a lot of physicians who have advanced specialties, subspecialties, began as internal medicine. And so they did residencies in internal medicine before they did one in cardiology or infection control or something like that. And those individuals were informed that they might be called upon to help in cases where that long ago internal medicine training was necessary. It was kind of an all hands on deck atmosphere. But that doesn't answer your question directly, but there were physicians, vascular surgeons, for example, I know, who were kind of idled during this time. They weren't able to see patients in the office, and there were very few vascular surgery emergencies. So, they're eager to get back to the elective care that we were talking about before.
Yeah, the contingency plans here that were not activated did something like that too. I believe it was also the case that sort of the first round of there were plans to train everybody, but the first round of the ROTA who would be put in, of the extras who would be moved over and put into place, were going to be those who were most recently off of the residencies in internal medicine.
Right.
They would have had that training rather than the folks who'd been out doing cardiology for 25 years. Something that people might also want to know is that there was a group of physicians from Intermountain And there were also several physicians from the U who went to New York at the worst of the peak.
Yeah.
Okay, another question. Do you see the same issues with Section 1557 of ACA coming into play as a vaccine or other prophylactic treatments are identified and developed?
The answer is yes, I do, because it's, again, I'm sorry, my phone is ringing in the background and I don't have any way to mute it. The best I can say for that is that anybody federally funded is subject to anti-discrimination regulations. And so allocation of vaccine, for example, that didn't involve individualized assessments. Now, this is on disability would be really, could be very problematic. This is one where it might matter whether there's one standard or different standards. For example, the Age Act allows disparate impact when a decision is based on a reasonable factor other than age. So if, for example, desires to retard spread because resulted in a disparate impact based on age, that if we were trying to allocate vaccinations to people who were most likely to be spreaders, and we thought the elderly weren't, and so there was a disparate impact based on age, the Age Act would permit it. So we're going to have to face, we might have to face that if vaccines are in very short supply.
Well, we're at the end of our hour. I want to thank Lowell and Leslie so very much for putting this program together and for participating today. This is great information, and what my biggest concern is, because it is shifting sands, we'll have to meet again in a month or the month after that, because things, who knows how things are going to change in the time period we have left. Again, for all of our participants who listened, we will have the video put on the law school's YouTube page within 48 hours, and we will be sending out the slides and your CLE certificates within that same period of time. Thank you again for your attention.